So hyponatremia, this is one another important topic. So normal levels, 135 to 140 is the normal 145 up to. Hyponatremia is defined as a serum sodium concentration that is less than 135 milliequivalents per liter. So this is a very frequent electrolyte abnormality in a hospitalized patient, and it is a very important predictor of death. Okay, and that is very important. So severity, we can divide it into mild, moderate, and severe. Mild is when the sodium levels are between 125 to 134. Moderate, 120 to 124. Severe, less than 120. But it is not the numerical values that we are looking at when we are defining hyponatremia. It is very important in terms of the symptoms the patient is presenting with, especially the neurological symptoms. Mild when the patient has mild headache, nausea, vomiting, fatigue, or confusion. Moderate when there is some kind of muscle cramps, fatigue, and a confusional status. Severe when the patient has delirium, significant delirium, restless, agitated, seizures. Okay, the patient can go into brainstem herniation, respiratory arrest, coma, and death. So that is about the severity. In terms of duration, you can divide it into acute, less than 48 hours, or chronic, more than 48 hours. So sodium is the principal cation in the extracellular fluid. So when we are looking into the body water compartment, so 40 liters, that is 60% of the body weight, the total body water volume. So when we are looking into intracellular and extracellular, the 40 liters, or 25, almost 25 liters are present in the intracellular. In interstitial, approximately 12, and the plasma volume is just 3 liter, that is 20% of the extracellular fluid volume. And the total body sodium is going to be almost 50 milliequivalents per kg, 95% of which is present in the extracellular fluid, and only 15% is going to be distributed in the intracellular space. So what are the main functions of sodium? So it is important in maintaining the blood volume. Okay, water balance, cell membrane potential, acid-base balance, nerve conduction, and remember the most osmotic sensitive organ is the brain. And sodium is an important component which contributes to the osmolality of blood. So classification, you can divide based on the levels, based on symptoms as moderately severe, mild, and severe. Time, acute and chronic. Based on osmolality, you can the normal osmolality is 250 to 295, wherein hypotonic, isotonic, or hypertonic. Based on the volume status, you can divide it into hypovolemic, hypervolemic, or euvolemic hyponatremia. A small word on the regulation of sodium. So when there is a volume deficit or when there is hyponatremia, the osmolality of the blood changes. So what contributes to the osmolarity? So we all know the formula for osmolarity is 2 times sodium plus blood glucose divided by 18 plus 1 divided by 2.8. So the normal osmolarity is 280 to 294. So this is contributed majority by the sodium, okay, because it is 2 times the serum sodium. So as the osmolarity of the blood changes, and also if there is a change in the volume, that is hypovolemia or hypotension, the hemodynamic status of the patient changes, the baroreceptors which are present in the aortic and the carotid bodies get stimulated, as well as the osmoreceptors which are present in the hypothalamus respond. Okay, the hypothalamus responds in the form of thirst, increasing the thirst and thereby increasing the water consumption. Other thing would be it will increase the production of ADP or arginine vasopressin, okay, or antidiuretic hormone, which is released from the posterior pituitary. So the action of this antidiuretic hormone would be on the kidneys. It mainly acts in the collecting duct. Okay, it causes water retention. So the other systems that will be activated or response to the low volume status would be the RAS and the sympathetic nervous system. So all these two systems help in conserving the water as well as increasing the sodium levels. Okay, so this is the main regulation of the sodium. So the three things that are involved is the arginine vasopressin or the antidiuretic hormone, the renin-angiotensin-aldosterone system, and the sympathetic nervous system. So whenever we are talking about the serum sodium level, always it depends on not only the absolute content of the sodium in the body, it also depends on the relative status of the total body water. Okay, it depends both on the sodium as well as the water. So dysnatremias are related to water intake. Okay, if it is hyponatremia, it could be due to water intake which exceeds the renal diluting capacity, whereas hypernatremia, inadequate water intake coupled with renal concentrating defects. So these are the reasons for dysnatremia. So when we are talking about hyponatremia, we can broadly classify based on the tonicity to hypotonic, isotonic, and hypertonic. So the true hyponatremia is defined as hypotonic hyponatremia. So what is hypertonic and isotonic? So hypertonic is due to translocational hyponatremia. So if there are excessive other osmotically active agents like mannitol or glucose, okay, so all these osmotically active agents cause excessive water shift of water from intracellular space to the extracellular space, thereby falsely resulting in a low sodium level. So what is pseudo-hyponatremia? Pseudo-hyponatremia is due to there are certain lab measurements which is artificially low because of the presence of certain molecules like paraproteinemias, high lipid triglyceridemias and all that. So what happens is that it measures the value in a wrong manner. So artificially low sodium values due to indirect ion selective electrodes. So if you're going to do it by a direct ion selective electrodes, the real value of the sodium will be known. So this is known as pseudo hyponatremia, and true hyponatremia is hypotonic hyponatremia. So here you can divide it into euvolemic, hypervolemic, and hypovolemic. So when you're talking about hypovolemic, the actual body content of the water is also reduced and the sodium content is also reduced. Hypervolemic, the body content of the water is increased and sodium may be maintained or low. Okay, euvolemic hyponatremia, the body water content is normal, whereas the sodium content is low. So when going into the causes of hyponatremia, so normal, low, and high osmolality. So normal is isotonic hyponatremia that we talked about, the translocational hyponatremias, that is paraproteinemia, hyperlipidemia like chylomicrons, triglycerides, and rarely cholesterol can cause. So high osmolality due to hypertonic hyponatremia. This happens due to hyperglycemia, mannitol, sorbitol, glycerol, maltose, okay, and some radio contrast agents also. Hypotonic, depending on the volume status, we can determine. So hypovolemic, wherein hypovolemic, here you look into the serum sodium levels. So if the urine sodium levels, if the urine sodium is less than 10, it means the patient is having an extrarenal salt loss, that is dehydration, diarrhea, or vomiting. If the urine sodium is more than 20, it means the kidney is excreting more salt, maybe due to diuretics, ACE inhibitors, nephropathies, mineralocorticoid deficiency, cerebral salt wasting syndrome. Euvolemic when there is SIADH, postoperative hyponatremia, generally hypothyroidism, SIADH, and adrenocorticotropin deficiency. So these are the causes mainly. Beer protomania and all these are the causes for euvolemic hyponatremia. So in hypervolemic, there are three main causes: congestive cardiac failure, liver disease, nephrotic syndrome, and sometimes in advanced renal failure. So based on the first, when you're evaluating a patient with hyponatremia, always assess the volume status. So in the absence of pseudo hyponatremia, you see you first rule out pseudo hyponatremia and translocational hyponatremia. Then you assess for the extra volume status of the patient. Look for signs of dehydration, or if there is pedal edema, a JVP that is elevated, IVC that is collapsing, or if it's non-collapsing, tachycardia, dry mucous membrane. So all these denote either the patient. By assessing all these variables, you can know whether the patient is hypovolemic or hypervolemic. Okay. So the next step in hypotonic hyponatremia will be you should look at the urine osmolality. So if the urine osmolality is less than 100, it can be due to a high volume intake. Okay, so there is a dilute urine that's passing on. So it could be due to primary polydipsia, low solute intake, or beer protomania. If the urine osmolality is more than 100, it could be due to either it could be due to mainly many of these factors like urine sodium. Next step would be to check the urine sodium. So urine spot sodium more than 30, less than 30. Less than 30, it could be due to extrarenal losses like diarrhea, vomiting, third space, and other and remote use of diuretics. And other causes would be heart failure, liver failure, nephrotic syndrome. If the urine sodium concentration is more than 30, it means diuretics or renal failure, which could be the main cause. If there is no diuretic use, it could be due to cerebral salt wasting, SIADH, or primary adrenal insufficiency. It could be due to hypothyroidism, okay, or secondary adrenal insufficiency. So that is how you proceed with your diagnosis of the etiology of hyponatremia. So next, specific criteria for SIADH. This is the Barter and Schwartz criteria for SIADH, wherein you have the serum osmolality. It is hypotonic, the osmolality is less than 275, and there is clinical euvolemia, okay? And the urine and the impaired urine dilution. So that is, urine osmolality is more than 1000 milliosmoles per kg. Urine spot sodium will be more than 30 in the absence of any other diseases like advanced kidney disease, cirrhosis, or heart failure. Absence of any alternate causes like hypothyroidism, glucocorticoid deficiency. So rule out other causes. Serum sodium is low, euvolemia, urine osmolality is high, and then urine sodium is high. So these are the major criteria. So additional criteria, your serum uric acid can be low, your fractional excretion of uric acid can be more than 10%. There is vasopressin or copeptin that can be elevated, and if you're going to give saline to this patient, there will be worsening of normal saline, can worsen hyponatremia. An abnormal response to volume water loading. So this is the diagnostic criteria. What are the causes of SIADH? Okay, multiple causes are there, starting from infective, respiratory, medications, malignancy, and neurosurgical etiology. The neurosurgical etiology, we know any patient who has had a subarachnoid subdural hemorrhage, GBS, meningitis, encephalitis, okay, HIV, sarcoidosis, tuberculosis by itself can cause SIADH, or any pneumonia can cause. Drugs, most of the anticonvulsants, carbamazepine, levetiracetam, antidepressants like sertraline, antipsychotics, okay, cyclophosphamide, some chemo drugs. And ectopic ADH production can be due to all these tumors like nasopharyngeal, mesothelial carcinoma, lymphoma, okay, and non ADH diuretic peptide release in prolactinomas. So these are the various causes. When we are going ahead with the management of euvolemic hyponatremia, that is confirm the diagnosis by, we saw the criteria already. Then how do you manage symptomatic, asymptomatic? If the patient is asymptomatic, proceed with fluid restriction. Symptomatic patient, if it is acute symptoms less than 48 hours, severe symptoms, give 3% bolus, and then look for improvement in the neurological status. If it's more than 48 hours, still severe neurological symptoms, administered 3%. If there are minor symptoms, just proceed with fluid restriction. So what about cerebral salt wasting? This is also one of the complications of neurosurgery or some bleeding SAH related. So what happens is that there is non-osmotic release of ADH and ANP. There can be this ANP and BNP that is elevated. So what happens after a neurological event? There is increased natriuresis and diuresis resulting in hypovolemia that actually stimulates ADH, and ADH results in water absorption. Thereby, there can be a clinical volume deficit plus a sodium that is low. Okay. So, and there is a loss of sympathetic tone also in the juxtaglomerular apparatus. So the patients with cerebral salt wasting classically present with a high volume urine. Actually, the urine output is very much elevated. When you look into the investigations, the serum sodium will be low serum osmolality, okay, and the urine spot sodium is going to be more than 40. Okay, it will be even in hundreds in patients with cerebral salt wasting. Because of high sodium as well as water loss, your urine osmolality will be high, more than 100. Okay, so that is about cerebral salt wasting. How can you differentiate between SIADH and cerebral salt wasting? The main clinical difference that you can appreciate between SIADH and cerebral salt wasting is that patient will be hypovolemic, whereas in SIADH, patients will be euvolemic. Okay, the urine output will be very, very high. So if you measure the CVP in this patients with cerebral salt wasting, it will be very, very low. That is the major difference between SIADH and cerebral salt wasting. Rest of the other parameters, serum sodium will be low, urine sodium will be very, very high in cerebral salt wasting, osmolality will be high, volume, yes, definitely in cerebral salt wasting, urate will be normal or it can be low also. So other features may not be differentiative. So why is hyponatremia important? Okay, we already saw brain is the osmotically very sensitive organ. So what happens when the sodium level drops? So when the sodium level drops, the osmolality in blood comes down. So the brain tries to adapt. Okay, there is low osmolality in the blood, in the brain, which is happening. So what happens? There is a period of rapid adaptation which happens in the initial 6 to 12 hours. So because of low sodium, there is expulsion of potassium as well as chloride also, and some electrolytes out of the brain, so that it tries to match actually loss of sodium, potassium and chloride. So it tries to match, resulting in a low osmolarity. So this happens in a initial 6 to 12 hour period, which is ionic loss. The next period in the 24 to 48 hours, there is a period of slow adaptation, loss of organic osmolytes, that is glutamine, taurine, that is most of the amino acids and the polyols, myoinositol, all those things reduces intracellular osmolality. and allows water to leave the cells. So if these are there, this will be osmotically more osmotic. So what happens is that water will diffuse from blood into brain, that will result in cerebral edema. So it's a compensatory or adaptive mechanism. Thereby it loses almost all of these amino acids to prevent edema. So this slow adaptation takes place over a period of 24 to 48 hours. So if, meanwhile, if you're correcting sodium, if you rapidly correct, what happens is that osmotic demyelination can happen. If you appropriately correct, there will be no cerebral edema that is developing. So the most important thing regarding hyponatremia that you're worried about is cerebral edema, and the complication of rapid correction will be osmotic demyelination. And that is why you classify the 48-hour time period into acute and chronic. So management of hyponatremia based on the symptoms you'll have to treat. Okay. If the patient has severe symptoms, moderately severe symptoms, what you have to do? Then again, without moderate or severe symptoms, then in chronic hyponatremia, how you can treat? Chronic hyponatremia with expanded extracellular fluid, that is hypervolemic, euvolemic, reduced volume, circulatory volume. So we'll see in all these categories. So we'll look into what are the different guidelines, what is the recommendations. Okay, when we are looking into severe in the sense, I'm not mentioning the numerical value, it is the symptoms: seizures, coma, risk of brainstem herniation. So severe, according to the European guidelines, they recommend 150 milligram of 3% saline bolus and repeat sodium within 20 minutes. Okay, when you give a bolus after 20 minutes, over 20 minutes, and check the serum sodium after 20 minutes, and you target and you look in for two things. One is you look into the neurological status, whether the patient's sensorium has improved or not. Next is you look into the serum sodium. If the sodium has improved to more than 5 millimoles per liter. So that is one aspect you're looking. So if there's no improvement, or if your target of 5 is not reached, again, you can give a bolus. So maximum you can give twice. Okay. This is as per the European. Whereas as per the American guidelines, they suggest 100 ml over 10 minutes thrice. Okay. In case of moderately severe, you can give 150 milligram over 20 minutes once. In American guidelines, moderately severe, 3% infusion can be given at a rate of 0.5 to 2 ml per kg per hour. So that's the recommendation for severe symptomatic hyponatremia. So next, the correction rates, okay, over the next 24 hours, what should you aim at? Okay, in European, the correction rates for severe, it's not been mentioned. Limit of 10 in a day is what is recommended. As per American, it's 8 to 6. In patients with high risk of osmotic demyelination. So there are a certain category of patients who are at high risk of osmotic demyelination, that we look into it in the next few slides. So in the patients, high risk patients, 6 will be your target. Other patients, 8. Moderately severe, 10 to 12. Okay, 8 in patients with osmotic demyelination risk. Okay, the goals of correction would be to prevent cerebral edema, prevent brain herniation, and prevent further severe symptoms. So if the symptoms have improved and you have reached a certain amount target, then you stop 3%. Measure your sodium 6th or 12th hourly daily. If the symptoms not improved, you need to continue an infusion, and then look in for your aim for increasing at least 0.5 to 1 millimole per liter per hour, and then check for the serum sodium levels. So there's a formula to calculate the deficit, and you can actually titrate the rate of your infusion as well. So the sodium deficit is the difference between your desired and the actual sodium. So, and then you multiply it by 0.6 into total body, that is weight. This will be your total body. 0.6 into body weight will be your body water and your actual desired sodium and actual sodium levels. So this will be a total sodium deficit in the body. And 1 liter of 3% contains how much? 530 milliequivalents. So you can calculate how much is the desired volume of 3% that you need to give, and the rate of correction if you're targeting 10 milliequivalents per day, and how much rate you should give it, so that you can decide based on this formula and the content in the fluid as well as your duration of correction. So next will be another formula. So the sodium infusate minus the serum sodium and the total body water plus 1. So if you're going to give 1 liter, so how much change in the serum sodium you can expect? So 513 milliequivalents in the infusate, and serum sodium, for example, if it's 120, and 42 will be your total body water plus 1. So somewhere around 390 divided by 43. So you can get a serum change almost kind of 10. 390 by 42, almost like 9 to 10 milliequivalents. So that will be your serum change in sodium if you are going to give 1 liter of 3%. So how much duration you want to give this 1 liter to attain 10 milliequivalents, that you will have to calculate. So any patient with acute without severe or moderately severe symptoms. So what will be your target? So you can give a 3% to get a, this is as per the European guidelines, okay? So you can target a 10 milliequivalent correction. There's no target limit, but you can give a bolus to improve the symptoms if there are mild symptoms also, but as such, there are no recommendations for this. In chronic hyponatremia, as per European guidelines, so chronic you divide it into 3 categories. One is hypovolemic, euvolemic, that is SIADH, and hypervolemic. So SIADH, just fluid restriction is recommended. Solute intake, that is urea, no lithium or demiclocycline, Vaptans against, okay, if the sodium is less than 125 and less than 130, does not recommend. In American guidelines, if you see for SIADH, that is euvolemic hyponatremia, Vaptans and demiclocycline along with fluid restriction. So this is recommended. Hypovolemic, normal saline or balanced salt solution as per European, American, normal saline. So hyponatremia with hyperolemia, fluid restriction, American guidelines, Vaptans. A small note on osmotic demyelination syndrome. So this is because of rapid correction of sodium. It can be central pontine myelinosis or extrapontine myelinosis. So extrapontine myelinosis can happen in thalamus, cerebral white matter, basal ganglia, and hippocampus. So the risk factors, so malnourished patient, alcoholism, hypokalemia, advanced liver disease, and chronic hyponatremia. So these are the risk factors for osmotic demyelination. So it can happen not immediately, 3 to 10 days after treatment also. So the main symptoms or the difference between central and extrapontine. In pontine myelinosis, the patient can be in locked-in syndrome, paresis, dysarthria, dysphagia. Okay, the patient cannot talk and will be kind of quadriplegic. So there is paresis, locked-in syndrome. The patient's sensorium can become low, loss of reflexes, pupillary, ocular, and motility disorders can be there. So this is about central pontine. Extrapontine myelinosis, there will be movement disorders. There can be neurobehavioral and general symptoms also. So movement disorders, there will be tremors, dystonia, chorea, athetosis, myoclonus, opsoclonus, gait disturbances, akinetic, rigid symptoms. Okay. And ataxia can be there. Behavioral, the patient can become just mute. Okay. Mutism, catatonia, depression, and epileptic seizures can also be there. There can be frontal lobe disinhibition, emotional instability, dementia, and primitive reflexes. So this is about osmotic demyelination. So there have been questions on vaptins also. So we'll be covering that. So AVP, so arginine vasopressin, the receptors V1A, B and 2. V1A is in smooth muscles of blood, vasoconstrictive action. V1B, anterior pituitary, regulate ACTH secretion. V2, collecting ducts, so it acts as antidiuretic effects. So this is secreted from the pituitary. So in response to osmolality and intravascular volume, that is low intravascular volume. So these are the primary stimulants. It acts on V1A, increasing the vascular tone. V2, regulate resorption of water from the collecting ducts. So what are the vaptins that are available? So the vaptins cause free water excretion. These are V1A, vasoconstriction, reclovaptin, V1B, nelivaptin, V2 is tolvaptan, satavaptan, moxavaptan, lixi. So these cause free water excretion. So when we are looking into the use in terms of hyponatremia, we are talking about tolvaptan and conivaptan. So tolvaptan is usually oral route, whereas conivaptan is both oral as well as IV. So the half-life is 12 hours, can be used in euvolemic or hypervolemic hyponatremia. Conivaptan, euvolemic or hypovolemic, and it can be used for a maximum of only 4 days. And do not contraindication is when the serum creatinine is more than 2.5, advised not to use it. When you're using tolvaptan, always make sure you monitor the liver function test. Okay. So we looked at the indication and mechanism of action. So it inhibits the ADH, that is V2 receptor, which act on the V2 receptors. Normal action of ADH is that antidiuretic hormone. It acts on the aquaporin 2 channels in the luminal surface, and thereby in the luminal surface is causes more absorption, the cyclic AMP pathway, more absorption of water, prevent diuresis. So it blocks ADH acting on the V2 receptors, and the aquaporin translocating or into the apical membrane. So it blocks this aquaporin too also. So water absorption does not happen. So there is more free water excretion. So that is the action of vaptins as such. So the next topic will be hypomagnesemia. So the normal magnesium level is 1.4 to 2.6 milligram per deciliter. Most of the magnesium is present in the bone, 60%, and 40% in the soft tissue. Usually, we will not get any symptoms unless the magnesium level is less than 1 milliequivalent per liter. Functions, when we are looking into the functions, it is an important intracellular cation, a cofactor in many biochemical reaction, a cofactor in many enzymatic reactions, and then platelet function, clotting and thrombus formation, maintenance of vascular tone, muscle contraction and relaxation, insulin regulation, neurotransmission, cardiac conduction. So these are the main functions of sodium. So etiology of hypomagnesemia. It can be due to decreased intake, redistribution, gastrointestinal or renal losses. So decreased intake can happen due to starvation, alcohol use disorder, anorexia, a terminally ill cancer patient or critically ill patient who is on total parenteral nutrition. Redistribution happens due to insulin, okay? Anabolic effects of insulin, refeeding syndrome, acute pancreatitis, ethanol withdrawal syndrome. Okay, gastrointestinal or renal, diarrhea, renal due to acute tubular necrosis, any diuretics. So normally we don't measure the ionized calcium level. but you can calculate just like TTKG, you can measure the urine excretion of magnesium. But here you remember it's not the osmolality, it's the urine magnesium level into the plasma creatinine, that is fractional excretion of magnesium divided by plasma magnesium into your urine creatinine multiplied by a factor of 0.7. The entire thing in terms of percentage. If this percentage, that is urine magnesium, remember this more than urine fractional excretion of magnesium more than 2% denotes renal wasting. Okay, the drugs which can cause hypomagnesemia include proton pump inhibitors. You know that amphotericin B causes hypokalemia, also hypomagnesemia. Pentamidine, proton pump inhibitors, loop and thiazide diuretics, digitalis, any chemotherapeutic drugs like cisplatin, cyclophosphamide, antibodies to EGF receptor blockers, okay, laxatives, so all those things. Clinical features of hypomagnesemia. So mainly cardiac, neurological, and then biochemical abnormalities. So cardiac wise, what you can see is there is prolonged PR interval, prolonged QT interval, widening of QRS complexes. There can be atrial fibrillation, ventricular tachycardia. Most important would be Taussig's D points. Okay. Hypomagnesemia, severe hypomagnesemia can also precipitate myocardial infarction. Similar to hypocalcemia, the Chopstick and Rossius sign can be positive in hypomagnesemia also. That is, tapping on the facial nerve causes twitching of the facial muscle. That is Chopstick. Rossius is carpopedal spasm due to an inflated BP cuff. Other signs would be confusion, tremors, seizures. Okay, associated abnormalities will be hypocalcemia, hypokalemia, and hypoparathyroidism. These can be always associated with hypomagnesemia. Why is that? Because parathormone release is regulated by low magnesium. So low magnesium impairs the release of parathormone. So thereby the patient can have hypocalcemia. And low magnesium inhibits renal potassium channels, leading to increased potassium excretion. So thereby hypokalemia. So in the kidneys, it causes hypokalemia. Hypoparathyroidism can also occur because of impaired release of parathormone. So these are the other electrolyte abnormalities. When you're evaluating, check in for other electrolyte levels as well. ECG to look in for arrhythmias. Fractional excretion of magnesium more than 2 denotes renal losses. It will help to distinguish between GI and renal losses. Genetic testing in terms of you're suspecting any other syndrome, genetic testing is advised. Treatment of hypomagnesemia. For acute symptomatic severe hypomagnesemia, unstable patients, 1 to 2 gram of IV magnesium sulfate over 15 minutes can be given. In unstable patients, I think you can supplement followed by that. Okay, the elemental, so 1 gram contains 96 milligrams of elemental magnesium sulfate, which is equal elemental magnesium that is equal to 8 milliequivalents. So 6 gram in 1 liter over 24 hours can be given, okay, in terms of severe symptoms. But when you're giving this, always monitor the deep tendon reflexes. Non-emergent, you can give 4 to 8 grams over a period of 24 hours. Okay. In terms of oral supplementation, you have medications that contain 64 to 71 milligrams of magnesium. A maximum elemental dose can be 240 in divided doses per day, up to a max of 720 per day in divided doses. Okay. When you are replenishing the magnesium levels, it should be done over a period of time, 2 days. Okay, usually it takes some time to replenish, especially when you're giving the oral formulations. And make sure if there is a renal dysfunction, you reduce the dose of magnesium supplementation. If the patient is on potassium sparing diuretics, So should be, so in case if the patient is severely hypomagnesic, you can also consider amiloride or triantin. So the next topic we'll be seeing, we'll start with the miscellaneous topics. I'll be covering 2 topics now. The Rose protocol for deresuscitation. So what is fluid overload, first of all, and what is deresuscitation? Fluid overload is nothing but the percentage of fluid accumulation that can be defined by dividing the cumulative fluid balance in liters by the patient's body weight. So cumulative fluid balance divided by the patient's body weight multiplied by 100. So that gives the percentage. More than 10% is defined as fluid overload. Okay. Deresuscitation is defined as active fluid removal in patients with fluid overload using drugs or any other methods like ultrafiltration. So what should be a target? A goal of 0 to negative fluid balance by day 3 to keep a cumulative fluid balance on day 7. Okay, so you should start 0 balance by day 3 to attain a negative balance by day 7. So what are the trials actually which support deresuscitation? So we know that fluid overload increases mortality. This is as per the SOAP trial. And the FACT trial mentioned there is a prolonged recovery in patients with ARDS and ALI. And if they can attain a negative fluid balance, it improves the mechanical ventilatory days. So that is as per the FACT trial. A vast trial mentioned worse mortality in septic shock patients. Okay, and this article by Dr. Malbrain 2014 mentioned that there is an increased risk of IAP in the patients who have a volume overload. So what are the signs of volume overload that you can look into? Every organ by organ, skin turgor, pitting edema, and then your capillary refill time again will go up. So your CVP will go up. The patient will become encephalopathic, absence of thirst. In fact, your blood pressures will be on the higher side. CVP will be high. Gastroparesis, renal blood flow will be decreased. There can be congestive nephropathy resulting in AKI. Okay, and pitting pedal edema, and you're looking at the splanchnic, the circulation will be affected, decreased blood flow to your splanchnic vessel, celiac and SMA. Congestive hepatopathy, there can be Rales orthopnea. So patient can have pleural effusions. There can be metabolic disturbances and anasaka. So every organ by organ, you will have to describe. So coming from renal, your perfusion pressure will go up. Interstitial pressure will, your venous pressure will go up. Interstitial pressure goes up. Blood flow decreases. Your GFR decreases. Hepatic congestion, cholestasis can happen. Hepatic compartment syndrome. GI, there is ascites, increase IAP, abdominal compartment syndrome. Your perfusion pressure will come down. Increased bacterial translocation, and microcirculatory flow will also come down. Cardiovascular, myocardial edema, conduction disturbances, diastolic dysfunction, as your your myocardial depression can be there, pericardial effusion, your global end diastolic volume. So all these things can go up. Respiratory wise, the compliance of the chest wall can decrease because of the increase in intra-abdominal pressure. There can be pulmonary edema, pleural effusions. Your lung volumes can go down. There can be increased work of breathing. Central nervous system, cerebral edema, impaired cognition, delirium, increased ICP, decreased perfusion pressure, increased intraocular pressure, intracranial hypertension. So all these features in the CNS, abdominal wall, tissue edema, poor healing, wound infection, pressure ulcers, and decreased compliance. So clinical signs we saw lab parameters, mostly hemodilution related, radiological signs, so X-ray effusions, B lines on ultrasound, and vexus. High-grade vexus is something that you need to look in for. Okay, assessment of the pulmonary function, your perfusion pressures and your pulse pressure variation, everything will be on the higher side. So this is a very important slide. It has a lot of details in it. So we'll go one by one. So what is the ROSE protocol? R stands for resuscitation phase. The initial few minutes of shock, okay, that is a phase wherein you focus on resuscitating the patient, the early adequate fluid management, or this is the early adequate fluid resuscitation. So this phase, we give volume to the patient. Start at 20 to 30 ml per kg in an hour, followed by boluses depending on many variables. Okay, what are the triggers that you looking for? Patient will be frankly in shock. Mean arterial pressure less than 65, global end diastolic volume index less than 640, CVP less than 8, PAOP less than 10, cardiac index less than 2.5, pulse pressure, systolic pressure variation, stroke volume variation more than 12 to 15, PLR positive, lactate more than 3. Okay, all these things denote hypovolemia, and you start with early adequate fluid resuscitation, that is first few minutes, and that is considered as the first insult or the initial insult. Okay, in the period of shock. Next phase, that is in the next hours. This is minutes. Next hours is a period of optimization. From hours, it goes to days. So this optimization phase focuses on organ rescue and maintenance, avoiding fluid overload. That is, you avoid fluid creep, aiming for a neutral balance. So here you're trying not to over resuscitate and just optimize your organ function. Here, stop if the patient is unresponsive. If the lactate normalized, PLR negative, if your MAP is a 10, so then your targets are almost achieved. So you stopped over resuscitating. Don't always be mindful of fluid creep, and aim for maintaining a neutral balance. So this phase is known as late conservative fluid management. Okay, and this is a phase wherein uh, the period of days to hours wherein ischemic reperfusion injury can happen. That is the second hit. Okay, the next phase followed by days later, wherein you enter after a period of stabilization from days to week. So this period is stabilization. You focus on organ support and hemostasis. Okay, you maintain late conservative fluid management. Okay, stabilization. So this phase, late conservative fluid management and organ support, defined by 2 consecutive negative fluid balance within the first week. So as your first week ends, you target, so day 3 0 balance, day 7 target negative balance. Okay, and then evacuation is after your stabilization phase. So that is when you aim for late goal directed fluid removal. So this late goal directed fluid removal is your deresuscitation phase, wherein you focus on organ recovery, resolving fluid overload with active goal directed removal of fluid with negative fluid balance. So when you have kind of attend your targets and your values go up, triggers of fluid removal start when there is a high global end diastolic volume more than 850, your PLR is negative, and then you look into your intra-abdominal pressure, your high vexus score. So these are the parameters wherein you look in for, and then you start doing a active fluid removal. And the last phase is when to stop removal. So stop removal, again, the patient's lactate can go up, PLR can become positive, PPV and SVV can again become positive more than 15, and the patient can have a low map. So this is when you have to stop fluid removal. So these are the things you need to remember. First is resuscitation, optimization, stabilization, evacuation, early adequate fluid resuscitation, late conservative fluid management, late goal-directed fluid removal. First hit is the initial insult. Second hit is the ischemia reperfusion. Third hit is the global increased permeability syndrome. Fourth, wherein you need to stop deresuscitation is when there is a risk of hyperperfusion. So this first few days is known as the ebb phase. From days to the time of recovery, that is known as the flow phase. So this is your ROSE protocol for deresuscitation. You can mention the when do you have to consider fluid removal. So VEXs, you can also mention VEXs in that, wherein you're looking for your IVC, then hepatic vein, portal vein, and renal vein Doppler. Okay, the hepatic vein reversal and the pulsatility in the portal vein, as well as the renal vein Doppler. So when your grades are high, then you think of fluid removal. So these are one of the criteria. Also, there has been questions on the 4Ds: drug dosing, duration, and de-escalation. Okay, it's not only for antibiotics, but also for fluid therapy. So what fluid to use? So saline versus balanced crystalloids. So you think of hyperchloremic metabolic acidosis with normal saline, appropriate therapy. So when do you start resuscitation? When do you stop? Combination of different agents, okay? Appropriate timing. So when you have to give and when you have to stop. So these are the various things that you can mention. Dosing. So how much you have to give based on your fluid responsiveness and tolerance, and what fluid you're going to give, like how much percentage of intravascular compartment that will be replenished, crystalloids versus colloids, pharmacodynamics you need to mention, and then toxicity. In case of colloids, we avoid HES because of renal injury. So duration, how long you want to give until the patient is responding and responding to fluids, and no signs of volume overload or not tolerating fluids. So that is when you stop. So other things is when your parameters are achieved, your goals of resuscitation are achieved. When do you start de-escalation? We saw, okay, resuscitation, de-escalation. So that is about the 4Ds also. You can write it up. So how do you actively do the de-resuscitation? So actively by starting diuretics. One is restriction of fluid intake, avoid fluid creep. Then start diuretics. Diuretics, the dose actually 20 to 80 if it is a naive patient. And then if it's already exposed to diuretics, you can give 2 to 2.5 times. Expect a urine output of more than 100 to 150 ml per hour. You can double the dose of diuretics and put the patient on infusion as well. Target a negative balance, okay? Target a negative balance until your goals are achieved, okay? Other method is the PAL approach defined by the Codman et al. In 2012. So the PAL approach is keeping a high PEEP for 30 minutes, that is equivalent to the intra-abdominal pressure, and then giving an albumin. So albumin, 20% albumin, 100 ml, you can give up to 200 ml on day 1, and you titrate the albumin to almost 3 grams per deciliter, so 30 grams per liter. To make sure the fluid is drawn from the circulation from the interstitial compartment to your plasma, and then try diuretics, okay? PEEP, albumin, and diuretics. Diuretics, you can give an infusion as well. So this approach has been initially tried in acute lung injury patients, And then they targeted a negative fluid balance and found a reduction in the extravascular lung volume water index. Okay, and the intra-abdominal pressure had also come down. So this is beneficial by decreasing the duration of mechanical ventilator days without compromising on the organ function. So this is your PAL approach. So these are the indices wherein you need to look into. Other thing would be renal replacement or a sled. You can do either a sled with ultrafiltrate or scuff, okay, or venovenous hemofiltration with ultrafiltrate removal. So when do you start fluid, stop fluid, remove fluid, and stop removal? So I mentioned all these targets. So you can remember this slide as well. Next topic is post-intensive care syndrome. So the definition of our interests do not limit to the ICU, extends to post-intensive care also. Okay, so the definition was given by in 2012. So new or worsening impairments in 3 domains: physical, cognitive, and mental health status arising after critical illness persisting beyond acute care hospitalization. So just remember, a patient admitted in our ICU has a SIRS response. Okay, always whenever there is a systemic inflammatory response that is going on, the body tries to compensate. Okay, a compensatory anti-inflammatory response sets in, and that usually is very strong and it is kind of prolonged. Okay, so when the patient recovers, okay, when the SIRS response come down, and usually the cars also come down and there is a phase of recovery. Most of the time, the patients either, if the SIRS response is overwhelming, there will be multi-organ failure and fulminant death that can happen. But if these two responses can resolve completely also, there can be a rapid recovery that can happen. But most of the patients, especially in patients who have a prolonged stay, have a prolonged inflammatory state, a state of persistent inflammation and a state of persistent compensatory anti-inflammatory response that goes on for days to months. Okay, so what happens during this persistent inflammation? There is no return to homeostasis. Kind of the body becomes cachexic. There is more catabolism. There is progressive immunosuppression. Okay, and this affects the patient in a long term without returning to baseline at all. And there is indolent death. So how our main aims should start not after the patient recovery. It should be targeted even when the patient is in the ICU having a uh, acute phase of critical illness. Okay, so we need to be aware of this post-intensive care syndrome. So the three domains, that is physical, cognitive, and mental domain. Physical is due to weakness, disuse atrophy, reduced exercise tolerance, impairment of activities. Okay, lung diffusion volumes and capacity will come down. The patient memory will go down, attention deficit, okay, mental speed, visual, spatial ability, all those things will go down. Mentally, the patient can be depressed. The patient can have post-traumatic stress disorder, anxiety, sleep disturbance, sexual dysfunction, and all that. Risk factors begin in the ICU: prolonged ventilatory days, more than 7 days, sepsis, multi-organ failure, hyperglycemia, systemic corticosteroids, and cognitive impairment. Delirium is a very important thing. Sedation, use of sedation, delirium, pre-existing cognitive impairment, and post-ICU mental illness like sedation, delirium, agitation, use of physical restraints, okay, contributes to all these things. So the main factor in post-intensive care syndrome, not only it is for the survivors, it extends to the family as well. Okay, this is PIC S. So this extends to the family. So in terms of survivals, you look into the physical impairment, cognitive impairments, and mental impairments and long-term prognosis. So the main barriers, when we look into the barriers, it depends on many factors, okay? The patient has to be rehabilitated. When you evaluate the patient, there will be multiple issues with the patient. The clinical features where we mentioned, so these will be the clinical manifestations. And the patient has to come for follow-up. Either the patient can be at home or in a subacute care center, but the patient has to come to the hospital for follow-up. There can be physical immobility, lack of health, transportation difficulty, and all that, distance from clinic to home. So all these are barriers to follow-up. So physical impairments, the main physical impairments will be acquired weakness in terms of critical illness polyneuropathy, okay, and critical illness neuromyopathy and myopathy. So bilateral symmetrical weakness will be there, defined by the Medical Research Council scale, a combined score of less than 48 in all of the testable muscle groups done twice 24 hours apart. So that is the definition of ICU acquired weakness. Pathology, it is due to microvascular ischemia, catabolism, immobility, and it can lead to skeletal muscle wasting, microvascular injury resulting in nerve ischemia, dysfunction of sodium channels, and injury to nerve mitochondria, okay, resulting in neuropathy, myopathy, or both. It usually takes a long time, several weeks to months to recover. Next is cognitive impairments, three domains: delirium, dementia, depression. So impaired memory, executive function, language, attention, and visual spatial abilities will be impaired. And this is mainly due to hypoglycemia, hyperglycemia, fluctuations in glucose, delirium in hospital, stress symptoms. Okay, there is a strong evidence that patients with ICU delirium has a stronger risk of long-term cognitive dysfunction. Okay, dementia also is one of the component of cognitive dysfunction, and there has been an association between dementia and ICU treatment as well. Pathophysiology not known, mainly a manifestation of brain dysfunction. So in terms of the patients, most of the survivors, actually 30% have anxiety, almost 70% end up with post-traumatic stress disorder. Pre-existing all these symptoms, alcohol abuse, are more contributory to the mental illness. When we come to the family, usually the families of survivors also face anxiety, depression, acute stress. A cluster of such psychological reactions is called post-intensive care syndrome family. So the cluster of all these, along with grief, post-traumatic disorder, and then anxiety, acute stress. So you combine these together. So the element of PICSF, that is depression, anxiety, post-traumatic stress disorder, burden, overload, activity restriction, complicated grief. So these are the components. So risk factors, especially the family member is a female, female gender, young relative patient, and then lower educational status, having a critically ill spouse, having more comorbids, being an unmarried parent, being unmarried, or a parent of a critically ill child. So these are the main risk factors of PICS-F family. Okay, so in pediatrics, another component. So family we saw, another thing is pediatrics, survived child and the family of the survived child. So instead of mental health, it is emotional health and social health. So that is the difference in pediatrics. So how do we prevent PICS? This can be done by ABCDEFGH approach. So we all know the ABCDE bundle. So same applies here. A for AV management, assess, prevent, and manage pain. B for breathing trials, including daily interruptions of mechanical ventilation, spontaneous breathing trials, spontaneous awakening trials, choice of analgesia, sedation, coordinated care and communication, delirium prevention, assessment and management, early mobility and exercise. So also involve the family, follow referrals, functional reconciliation, and good handoff communication, hand out materials on PICS and PICSF. Next is nutrition. So always make sure the nutritional status is appropriate and maintained. Okay, energy delivery, protein intake necessary for muscle synthesis. If there is energy depth because of catabolism, always try to supplement with parenteral nutrition if the enteral nutrition is not adequate. Overfeeding can also induce autophagy and impairment. Okay, appropriate energy delivery, avoid overfeeding. So other aspects, so we looked in for A, B, C, D, E, F, G, H. Next is nutrition, environment managing management for healing. This is also important. So make sure in the ICU itself, earplugs, music therapy, improved quality of sleep, avoid noise reduction devices. Nursing care for pigs. So nurses are the people who are like remaining with the patient, close to the patient. So they need to know the priorities, living condition, prior living condition of the patient prior to hospitalization. They can help in early rehabilitation. Intensive care diaries is something that is being recommended. So there can be a diary that can be maintained, and each a family member or a medical person writes something for the patient, and the patient can have notes for himself. This will be handed over at the time of discharge. So other thing would be follow-up clinics and PICS every 3 to 9 months to support rehabilitation. So this is all about PICS, ICU acquired weakness and critical care illness related.